Normal variants of sinus rhythm. Sinoatrial node anatomy. The sinus node is a large spindle-shaped structure, with the central body and peripheral part, 10 to 20 mm long, and 2 to 3 mm wide, located in the upper lateral aspect of the right atrium, RA, near to the junction of the superior vena cava, SVC, embedded between the sulcus terminalis and the crista terminalis. It often surrounds the sinus nodal artery, which is a branch of the right coronary artery in 60%, or the left circumflex artery in 40%. Its artery is disproportionately large, and its perfusion pressure can affect the sinus rate. Rate decreases with distension of the artery, and increases with its collapse. It has got dense innervation with adrenergic and cholinergic muscarinic nerve terminals. Both can cause a shift in the principal pacemaker site, that can result in changes in P-wave morphology in the ECG. Histologically, the sinus node is composed of principal pacemaker cells, and other cells with slower depolarization rates, which serve as backup pacemakers. Pacemaker activity. The sinus node cells discharge synchronously, creating individual wave fronts, that merge to form a single wave front. The pacemaker locus within the sinus node can shift to cells discharging relatively faster, in its upper portion, or relatively slower, in its lower portion. Sinoatrial exit sites. The sinus node is insulated from the surrounding atrial myocytes, except at certain exit sites. Different pacemaker sites, within the sinus node, can select different exit sites to the atria. Autonomic modulation of the heartbeats. Enhanced vagal activity can produce sinus bradycardia, sinus arrest, or sinoatrial block. Conversely, increased sympathetic activity can increase the sinus rate, and can reverse sinus arrest and sinoatrial block. Vagal stimulation causes rapid onset and offset of sinus node discharge, allowing dynamic beat-by-beat vagal modulation of the heart rate, while sympathetic stimulation causes slow onset and offset. Periodic vagal bursting, which occurs each time a systolic pressure wave arrives at the baroreceptor regions in the aortic and carotid sinuses, induces phasic changes in the sinus cycle length. Vagal activity may slow the sinus rate without affecting AV node conduction, or can prolong AV node conduction time without affecting the sinus rate. Most authorities consider the following three sinus rhythms as normal variants. 1. Normal sinus rhythm. 2. Sinus arrhythmia. 3. Wandering pacemaker. ECG in normal sinus rhythm, NSR. NSR is present when the impulse arises in the sinus node, at a normal rate, and conducts normally. Any abnormality in impulse initiation or impulse conduction is an arrhythmia. NSR is characterized by the following. Normal sinus rate, 60 to 100 beats per minute. The rhythm is usually regular, or with slight irregularity. Normal P-wave direction, it should be positive in leads I, 2, AVF, and V3 V6, and should be negative in AVR. In other leads, 3, AVL, V1 and V2, it is variable, could be positive, negative, or biphasic with a positive component followed by a negative one, or vice versa. Normal PR interval. 1 to 1 atrioventricular conduction. And normal QRS duration and configuration. Sinus beats arise at sinus node and propagate to the AV node, downwards and to the left, thus, P waves should be positive in leads I, 2, AVF, and V3 V6, and should be negative in AVR. Faster sinus rates, for example, with sympathetic dominance, arise from more superior locations in the sinus node, the P waves become more positive in leads 2 and AVF. On the other hand, slower rates, for example, with vagal dominance, arise from more inferior locations in the sinus node, and P waves become less positive in leads 2 and AVF. It is usually, however, enough to look at leads 2 and AVR. If P wave is upright in 2 and inverted in AVR, it should be of sinus origin, or rarely an atrial focus close to the sinus node. Sinus arrhythmia. Sinus arrhythmia is the most common arrhythmia. It is most common in children and decreases with age. In ECG the P-wave morphology is normal, and the PP intervals vary by more than 160 millisecond. Types of sinus arrhythmia. 1. Respiratory sinus arrhythmia, cardiac cycles shorten, heart rate increases, with inspiration, and lengthen, heart rate decreases, with expiration. Breath holding eliminates the arrhythmia. 2. Non-respiratory sinus arrhythmia, of unknown mechanism. 3. Ventriculophasic sinus arrhythmia, in advanced AV block, PP cycles containing QRS complexes are shorter than those without QRS complexes. The mechanism is unknown but thought to be due to augmented sinus node blood supply and right atrial stretch, when ventricular contraction occurs between two P waves. In sinus arrhythmia, the PP intervals vary by more than 160 millisecond. PP variations less than 160 millisecond are considered within normal. Ventriculophasic sinus arrhythmia occurs in advanced AV block, PP cycles containing QRS complexes are shorter than those without. Wandering pacemaker. Wandering pacemaker is considered, by some, a variant of sinus arrhythmia. It usually occurs in the young and in athletes, probably due to augmented vagal tone. In wandering pacemaker, either there are varying exit points of the impulses from the sinus node, or the impulses wander from the sinus node to the low atrium and back. This rhythm should not be confused with multifocal atrial tachycardia. ECG in wandering pacemaker shows cyclic changes in RR intervals, gradual shortening of PR interval from beat to beat, gradual change of the P-wave contour, until its direction may be reversed, and may be lost in the QRS, and the cycle is repeated. Thank you.